So good evening all. Today we'll discuss in another 35 to 40 minutes on transcranial Doppler, its working principle, what options we have, what are the advantages, what are the limitations, what are the clinical applications with its limitation, with a backup of some evidence for utility of this transcranial Doppler. So in the recent era, so we started using transcranial Doppler in intensive care unit, particularly for subarachnoid bleed patient to identify cerebral vasospasm and to initiate an appropriate vasospasm preventive measures, or to schedule an angio when we have some sort of suspicion. We done a TCD and we are able to screen them with a TCD, and appropriately we can schedule an angio and proceed for either some sort of intervention to prevent that cerebral vasospasm, or maybe pharmacological therapy and all. So basically this transcranial Doppler is called as the doctor's stethoscope of the brain. So important and established applications of TCD include detection of right to left shunt, so cerebral vasomotor reactivity, so monitoring flow velocities for stroke prevention in sickle cell disease as a supplementary diagnostic test for confirmation of brain death, continuous transcranial Doppler monitoring during systemic thrombolysis. See, some of the utility of TCD are very new, some are age old, some are evolving. Okay, so basically we have lots of utility which are adding into the list when it comes to TCD clinical utility. So transcranial Doppler and transcranial color coded duplex sonography, they differ in terms of the frequency. So to achieve acceptable signal to noise ratio, system utilizes Doppler with lower bandwidth, larger and less defined sample volume. So TCD system which had 2 megahertz pulsed wave Doppler. So TCCS, so transcranial color coded duplex sonography, which is having a frequency ranging from 1.8 to 3.6 megahertz phased array sector transducer. So basically what we use transcranial Doppler probe is going to be a lower frequency. Lower the frequency, more will be the better penetration. Okay, we know that for putting a central line or a pneumothorax, we use vascular probe, which is around 12 to 14 megahertz. Okay, but here for TCD we use 2 megahertz pulsed wave Doppler probe. So what options we have for TCD nowadays? We have a continuous transcranial Doppler monitoring device. So there is a company called Rymed, which we recently have in our unit. So if you attach the headgear, okay, so we are able to get a continuous transcranial Doppler monitoring. So that is what we exactly need in the bedside, because see, when a patient is having some sort of subarachnoid bleed, so he underwent coiling or clipping, so then we need to monitor him to detect early the vasospasm and all. Suppose you done transcranial Doppler in the morning, again in the afternoon, or maybe in the evening, so you might miss the opportunity to identify this vasospasm and all. If you have a continuous monitoring, so we are able to get an idea about the vasospasm in a dynamic way. So otherwise we have a regular ultrasound machine with a probe available. So currently GE machine, Philips advanced machines and all, so they given an option for doing a transcranial Doppler with a specific probe and all. So we have both the options in our unit. So we can do with a continuous TCD machine, or maybe so intermittently with a regular ultrasound with an add-on probe for TCD. So that is also possible. So these are the broad way of available options for TCD. So again, elaboratively, so we have lots of indications for TCD to detect intracranial stenosis and occlusion in major basal arteries, evaluation of intracranial hemodynamic effect in the presence of extracranial occlusive disease, monitoring of intracranial vessel recanalization in acute stroke, monitoring of intracranial cerebral hemodynamics, like after subarachnoid hemorrhage in patients with increased intracranial pressure during or after extracranial revascularization procedure like carotid endarterectomy, balloon angioplasty, before or during neuroradiologic intervention like balloon occlusion, so coiling of like AV malformation during open heart surgery, evaluation of brain death, so detection and quantification of right to left shunt, so particularly in case of patent foramen oval. So there are some functional tests we can do with the TCD. Stimulation of intracranial arterioles with the CO2 or other vasoactive drugs. Then we can see, so vasomotor reactivity to this carbon dioxide or changes in the oxygen level are by an effect of this vasoactive drugs and all. So language lateralization before neurosurgery, these are some of the functional uses. External stimulation of visual cortex, so compression test to assess collateralization capability. So means when we have some sort of occlusive disease, so we can get an idea, is there any possibility of the collateral formation or not? So that also we can get information from that of the TCD. So there are new indication application, brain perfusion imaging, including, so it helps say as a supplementary test during cerebral arrest. Okay. So R for brain death declaration, we can use it as an ancillary test. So ultrasound assisted thrombolysis, which is a newer application, which is having some like clinical utility in terms of easing the thrombolysis process and all, which we'll discuss later. So we need to understand there are some factors which affect TCD interpretation. So diameter of the vessel, so PCO2 value, partial pressure of the carbon dioxide, because we know that. So carbon dioxide plays a major role in cerebral like vasodilatation or vasoconstriction. So blood pressure of the patient, anesthetic agents, okay, so they have some sort of vasodilatory effect. So vasoactive drugs, so insonation angle, means when we are doing the like TCD with a regular ultrasound probe, so the angle is going to make a huge difference in terms of getting the image quality and also assessing and interpretation of that image. So physiological factor again, like PaCO2, age, gender, hematocrit particularly is having an impact in terms of the flow velocity and all. That's why, so when we do like MCA velocity assessment to get an idea about the like vasospasm in the post subarachnoid bleed patient, we see Lindegard ratio because it is going to take care and negotiate all the effect of PCO2 and that of the hematocrit. So it makes sure these are not the confounding factor to have increase in velocity which mimic like a vasospasm when we do something called Lindegard ratio, which we'll discuss later. Okay, so we need to have some general consideration. So patient should be rest comfortably when you are planning to do a TCD in an awake patient, particularly in sickle cell anemia and all. So position of the patient and like interpreter should be optimal. Accessibility of the ultrasonic windows within the skull that can be penetrated with the ultrasonic beam are often limited. Remember, so getting a window in the occipital posterior circulation is very, very difficult. So arteries at the base of the skull vary greatly in respect to size, course, development, and site of access. So these are some of the consideration or maybe a bit of limitations when we do the TCD. The power measured behind the skull is rarely more than 35% of the transmitted power. So that is what I told. So behind the skull in the occipital region, in the posterior circulation, penetration is very, very poor. It may not be more than 35%. So of the total transmitted power. So that we need to remember. So based on the pulse echo technique, so the 4 commonly employed acoustic windows in adults are means, so in which place we can place the probe to do this transcranial Doppler. Okay, we have temporal window, so we can get middle cerebral artery, anterior cerebral artery, posterior cerebral artery, and posterior communicating artery. So orbital, so we can get ophthalmic artery view, internal carotid artery siphons. Okay, so suboccipital, so allows insonation of the vertebral artery and basilar artery. Submandibular, evaluate the distal cervical branches of the internal carotid artery. So and the basal artery can also be evaluated through the transforaminal approach. It is a direct insonation or visualization through the foramen magnum. So basically, we have something called so temporal window. Okay. Then this is the orbital window. Okay, so this is the suboccipital window. So this is the submandibular window. So these are the 4 basic windows through which we can opt transcranial Doppler. So this is the TCD machine. So this is the TCCD, means TCD probe. This is the TCCD probe. Okay. So these are some of the options as I told. So submandibular, temporal, orbital, and that of the occipital approach to get an window of the transcranial Doppler. So we go one by one window. So when we have this transtemporal insonation or transtemporal window, so a red color signal, that means towards the probe between like 40 to 65 millimeter is representing ipsilateral middle cerebral artery. So this we need to remember. A blue signal between 65 to 80 millimeter ipsilateral. Okay, so it is going to give the ipsilateral again. So like in between 65 to 80, so it is ipsilateral ACA or basically PCA. Okay, so a red signal beyond 80 millimeter contralateral A1 branch of the anterior cerebral artery. A bidirectional signal obtained at 60 to 70 millimeter represent ICA bifurcation. So this is again like MCA, the depth is in between 30 to 60. So ACA is 60 to 75, PCA is around 60 to 75, ICA is around 55 to 65. So again, the normal velocity, so we need to understand like around on an average around 55 centimeter per second for MCA, 50 for ACA, around 40 for PCA, again 40 for ICA. So towards the probe is in like MCA, PCA, okay, and that of the ICA. Away from the probe is going to be like ACA territory. So this is about the transtemporal window. So the ultrasound probe is slowly oriented posteriorly by 10 to 30 degree in the temporal window. Usually there is a flow gap followed by a flow signal from the PCA. Means from MCA, when you do some sort of like orientation 10 to 30 degrees in the temporal window towards posterior, so there will be some flow signal gap will be there. Again, the flow signal starts. So that is from the PCA. Flow signals directed towards the probe, that is the P1 branch of the posterior cerebral artery. Away from the flow is P2 segment of the PCA. Both segments are visualized at a depth of 55 to 70 millimeter, and absence of the flow gap while moving the transducer posteriorly after MCA or ACA helps in evaluating posterior communicating vessel also. This is how it looks like MCA. Okay, towards the probe, red, ACA is blue, PCA, okay, P1 and P2 somewhere here we are going to get. So this is the like MCA here. This is the like transtemporal, how we are able to get an like window. So this is the tracing of the waveforms. This is the systole, this is the diastolic velocity. So this is the index marker. Okay, screen left is this part. Okay, contralateral temporal bone. So this is the third ventricle, how it's going to appear. So basically, so when you do temporal window, we are able to get an MCA, ACA, PCA, and that of the posterior communicating artery. So this is how we are going to get like some sort of the waveform. This is an example of left middle cerebral artery transcranial Doppler. So we get a peak systole, okay. So then we get a end diastole, and somewhere we get a mean velocity. If you see the systole, it is somewhere around 107 centimeter per second. So diastole is around like end diastolic volume is somewhere is around like 44.2. Mean velocity, it is bit more than that of the 60, somewhere this we call it as a mean velocity, that is around 63.1. So then we have something called resistive index, pulsatility index, okay, systole by diastole, heart rate, all those things we are able to get by using like TCD. So we'll go what are the clinical utility of pulsatility index and resistance index, also the peak velocity, mean flow velocity, and end diastolic velocity. Okay, so then move on to transorbital insonation. So the transducer placed over the eyelid and angled slightly medial and upward. Okay, so this is how we are going to do. The probe is medial and little bit upward in the transorbital window. Flow signals at a depth of less than 60 millimeter towards the probe is ophthalmic artery. So ICS siphon, internal carotid artery siphon, is a curved artery. The flow signals may be directed towards or away from that of the probe. So basically here we are going to get the towards the probe is ophthalmic artery. Okay. So then subclinoid part of the ICA may be towards or like away. So if it is a supraclinoid, it is going to be looking away, and towards the probe is subclinoid, and geno of the ICA siphon, it looks like this. So here ophthalmic artery and internal carotid artery siphon we are going to appreciate by doing transorbital window. So then it is the suboccipital window. So that is also through the transfemoral, means transforaminal route also. So it is utilized for the evaluation of vertebral and basilar arteries throughout their lengths. So probe placement is midline between foramen magnum and the spinous process of the first rib. The Doppler beam is aimed at the bridge of the nose. So sample volume depth, if you see vertebral artery somewhere at the depth of 40 to 95 millimeter, aim right and left of the vertebral arteries, flow is away from the signal. So basilar artery at the depth of 70 to 115 millimeter, flow is again away from that of the signal. So this is the suboccipital window. So how we are going to place the probe? Okay, so this is the probe in the suboccipital region. Okay, so in between the like first rib spinous process and that of the foramen magnum. So here we are going to appreciate so right vertebral artery, left vertebral artery, and that of the basilar artery. So these are the three structures so which we are able to like appreciate in the suboccipital window, that is also called as transforaminal window. So by turning the probe slightly upward and medially from the depth of somewhere around 75 to 110 millimeter, basilar artery may be obtained or insulated. So may also be obtained through the transforaminal window. So transducer just below the occipital protuberance and towards the nasal bridge. The flow from basilar artery is away from the probe in the transforaminal window. So suboccipital and transforaminal are similar. So only like we are going to put the transducer just below the occipital protuberance towards the nasal bridge. So then it acts as a transforaminal window. So then what about submandibular window? So the distal segment of extradural part of the internal carotid artery is the target for submandibular window. It is used for the detection of internal carotid artery dissection, chronic ICA occlusion, okay, velocities for calculating Lindegard ratio, that is the extracranial part of the internal carotid artery velocity, okay, mean flow velocity will take when you calculate this Lindegard ratio to exclude the confounder of hypoxia, hypercapnia, or hematocrit, which have some effect on the vasospasm, mimicking, okay, in terms of the velocity assessment. So this is the submandibular window. We are going to place the probe here. So transcranial Doppler examination of the petrous portion of the internal carotid artery by submandibular approach. Okay, so this is the internal carotid artery. So can be traced from depth somewhere like around 25 to 80 millimeter, corresponding to C5 segment of the internal carotid artery. So representative like this is the vessel. So basically somewhere between 25 to 80 we are able to get an idea about the like extradural or extracranial part of the internal carotid artery by using the submandibular window. So we need to understand some of the description of some of the terminologies. Okay, so the normal spectrum of waveform is going to be a sharp systolic upstroke and stepwise deceleration with a positive end diastolic flow. Remember, always end diastolic flow is positive. If it get reversed, so then it gives some clue about the cerebral like cutoff or maybe cerebral arrest. So peak systolic velocity, this is the first peak on the TCD waveform from each cardiac cycle. A rapid upstroke represents the absence of severe stenotic lesion between the insulated intracranial arterial segment and that of the heart. So end diastolic velocity, okay, it lies somewhere between 20 and 50% of the peak systolic velocity values, so indicating a low resistance intracranial arterial flow pattern. So mean flow velocity calculated as end diastolic velocity plus 1/3 of the difference between peak systolic and that of the end diastolic volume. So middle cerebral artery should have the highest mean flow velocity among all major intracranial arteries, means including anterior cerebral artery, posterior cerebral artery, or like posterior means communicating artery, or vertebral and basilar artery. So mean flow velocity for MCA is the maximum. So these are some of the measured variables by using TCD, and we have some of the derived variables also. If you see, we are going to get a mean flow velocity. Okay, so peak velocity here, it is more than 120. So it is around 128. End diastolic velocity is somewhere around like 58, 59. So this is just here end diastolic velocity. And we have a mean flow velocity, which is just above the 60, that is around 86. Then we have pulsatility index. Okay, so resistance index and ratio of systole to diastole and all. So peak systolic velocity in centimeter per second. So it's the maximal systolic velocity in centimeters per second during a cardiac cycle. End diastolic flow velocity in centimeter per second. So at the minimum of the peak envelope. So this is the minimal of the peak envelope. So mean flow velocity again in centimeter per second. Estimated mean flow velocity, so which is the time average value of the envelope, so divided by maximum velocity over one cardiac cycle. So mean flow velocity is equal to, as I already told, so it is the end diastolic flow velocity and 1/3 of the peak systolic velocity and that of the end diastolic velocity difference. So how to calculate this pulsatility index? So pulsatility index is the peak like systolic flow velocity minus end diastolic velocity divided by mean flow velocity, that we call it as a pulsatility index. It is having a role in some sort of like troubleshooting and some diagnostic modality we'll discuss later. Then we have something called Porcelet resistance index. So pulsatility index is Gosling and King pulsatility index, and Porcelet resistance index is like peak systolic minus end diastolic divided by the peak systolic. Then we have Lindegard ratio, as I already told. So this is through the submandibular approach we can get like extracranial part of the internal carotid artery mean velocity. So middle cerebral artery mean velocity divided by extracranial part of internal carotid artery mean velocity, that we call it as a Lindegard ratio. So somewhere 1 to 3 is the normal value of the Lindegard ratio. So we'll go one by one. So pulsatility index gives an idea about the flow resistance. Flow resistance is usually assessed by this PI, that is the pulsatility index, calculated by subtracting end diastolic from that of the peak systolic divided by the mean flow velocity. Most frequently used TCD parameter to determine the flow resistance. The value more than 1.2 represent high resistance to blood flow. Okay, so basically this is the peak systole, this is the diastole. Okay, so this is the mean flow velocity. So peak systole minus diastole divided by systole is the resistive index. So systole minus diastole divided by the mean velocity is the like pulsatility index. So if it is more than 1.2, there is an increase in resistance to that of the blood flow. So then resistance index used to assess the again flow resistance, it represents a flow resistance distal to the site of insunation. Means you put a probe, so we want to get an idea from that point of the vessel distally is there any flow resistance or not. So then we can use resistance index. So basically resistance index is the systole minus diastole divided by systole. Systole minus diastole divided by mean is the pulsatility index. So resistance index value, so below 0.75 is normal. If it is more than 0.75, there is a resistance distal to the site of insunation. So spectrum with abnormal systolic flow acceleration. See, I told, so there should be a rapid upstroke of the systole and a diastole in a like stepwise manner in the positive side of the waveform. But when we have an abnormal systolic flow acceleration, see this looks like abnormal, it doesn't look like a rapid upstroke here. Okay, so seen distal to proximal steno-occlusive lesion, means we have a steno-occlusive lesion. So distal to the proximal steno-occlusive lesion, so the appearance of waveform is going to be abnormal systolic flow acceleration, we call it as. The waveform shows delayed systolic flow acceleration, flattened systolic upstroke. It looks like flattened here and a slow diastolic deceleration. It is not a rapid diastolic deceleration. It looks like a slow diastolic deceleration. So end diastolic velocity is usually more than 50% of the peak systolic velocity due to compensatory distal vasodilatation. I told it should be somewhere between 20 to 50% of the peak systolic velocity. But here, if you see end diastolic velocity, it's going to be like more than the 50%. If this is considered somewhere around 30-35 as the peak systolic velocity, it is more than 50% is the end diastolic velocity. So that is because of the compensatory distal vasodilatation. It is also called as blunted flow signal. So overall, it is an abnormal systolic flow acceleration. So gives an idea about the steno-occlusive lesion. So then how we can get an idea whether a patient is having an intracranial stenosis by using like transcranial Doppler. So focal stenosis increases the flow velocities represented by bruit or bruit, seen as a symmetrical artifact on either side of the baseline. So if you get an artifact like this, okay, this is the peak systolic wave velocity. So this means patient is having a intracranial stenosis. Okay. So compared with CT angiography, TCD demonstrate around 80% sensitivity and around 94% specificity in detecting intracranial stenosis. So if we get a bruit like on either side of the baseline, so then it means patient is having intracranial stenosis. There are some cutoff values for various territory to get an idea about the stenosis. So M1, M2, middle cerebral artery. So normal mean flow velocity should be less than 80. So mean flow velocity cutoff for 50% stenosis if it is more than 100. So A1 territory of anterocerebral artery. So normally it is less than 80. So we don't have established cutoff, but proposed it is around more than 90. Okay, so 90%, then more than 90 value, then the patient is going to have a 50% stenosis. So ICS iPhone less than 70, more than 90 is abnormal. So PCA less than 50 is normal. So any value of more than 70 is abnormal. Vertebral artery less than 60 is normal, more than 70 is abnormal. Basilar artery, so less than 50 is a normal mean flow velocity. So if it is more than 70, so then there is a 50% stenosis in the basilar artery. Okay. Then spectrum with irregular rhythm. So we have some sort of peak systole again. So diastole we have, again the systole is very low, again it is increased. So if you get an irregular rhythm, so identify cardiac rhythm abnormalities like atrial fibrillation by TCD as a variable Doppler spectra and that of the velocity variability also. So the cardiac cycle with the highest flow velocities is used for measurement of various parameters. So basically, so TCD also tells patient is having a atrial fibrillation or not with the spectrum of irregular rhythm. Okay. So TCD monitoring for spontaneous emboli. So some of the microembolic signals we are able to identify by TCD. So extended monitoring of an intracranial artery distal to the steno-occlusive site can detect spontaneous microembolic signal, which we call it as MES, and quantify the embologenic potential of atherosclerotic plaque. So basically, you do the TCD, okay. So an artery distal to some steno-occlusive site, if it is showing some sort of microembolic signal which tells about the atherosclerotic plaque and its embologenic potential also. So detection of even a single MES during 40 minutes of continuous monitoring is considered as a clinically significant. So this is how it appears. Okay. So these are the microembolic signal generation from a distal part of the steno-occlusive vessel. So which tells, okay, there is more embologenicity. Okay, if you have monitored for 40 minutes, if you get one signal like this, you have to be very careful. It gets an idea about the probability of the high risk for the stroke and all. Okay. So the International Cerebral Hemodynamic Society describe this MES, that is microembolic signals, as random occurrence during the cardiac cycle. So brief duration, which is less than 0.1 second. So high density, more than 3 decibel over a background. So primarily unidirectional signal. So audible component, like we might get some chirp, whistle, or pop-up sound. So the presence of MES and TCD distal to high-grade asymptomatic stenosis of the internal carotid artery identify patients at a high risk for stroke. So this is something new. So we are able to get an idea of what is known as like microembolic signal. So this looks like an abnormal, some sort of artifact in the like TCD waveform. If you get a single abnormal microembolic signal during the 40-minute continuous dynamic assessment of the TCD, gives an idea about patient is high risk to develop the stroke. Okay. So can we use TCD to get an idea about right to left shunt, okay, in patent foramen ovale? So TCD bubble test helps in detecting right to left shunt, so more sensitive and specific than transesophageal echocardiography for right to left shunt detection, as well as for quantifying the functional potential. So these are some of the grading: grade 1, 2, 3 up to grade 5. If you see, grade 5 looks like a screen. Okay. So basically, it not only identify right to left shunt with a good sensitivity and specificity as compared to transesophageal echo, we can also quantify into grade 1 to grade 5 of this right to left shunt. So we have international consensus criteria: grade 0, no like microembolic signal. So 1 to 10 is the frequency, means numbers of microembolic signal, grade 1. So 11 to 30 is grade 2, and more than 30 with a shower or curtain appearance. So this looks like a curtain appearance, okay, shower screen appearance. So then it is a grade 3. Again, we have Spencer's, so logarithmic scale. Again, no MES, grade 0, 1 to 10 grade 1, 11 to 30 is grade 2, 30 to 100 is grade 3. So 101 to 300 is grade 4, more than 300 is grade 5. So obviously, which appears like a shower or curtain appearance in the TCD waveform. Okay, this is how it looks when you have a significant severe grade right to left shunt with a patent foramen ovale. Okay, so what about the idea getting on this vasomotor reactivity by using TCD? So vasomotor reactivity represent the response of cerebral circulation to various vasomotor stimuli for maintaining a near constant blood flow. We know that there are some insults which act as a vasodilatory effect on the cerebral circulation. Some insults can act as a vasoconstrictor. So to get an idea about the cerebral circulation response, okay, to these stimuli, which helps in maintaining the homeostasis of constant blood flow, that we call it as a vasomotor reactivity. So the subject is asked to hold his or her breath for a minimum of 30 seconds while MCA were being monitored with TCD. You are doing a transtemporal, getting an MCA waveform. You have to tell them to hold the breath for 30 seconds minimum. So MCA flow velocities are noted 4 seconds after breathing is restarted. Okay. After 30 seconds, you have to tell the patient or like who is on whom we are performing the TCD to start breathing. 4 seconds after, you need to see the MCA velocity and all, means MCA waveform. So there is something called breath holding index. So it is the maximum flow at the end of at the end of breathing and baseline maximum flow. This difference divided by baseline maximum flow velocity into 100 divided by seconds of breath holding. So 30 seconds, 45 seconds, whatever it may be. If the breath holding index is less than 0.69, is considered to represent an impaired cerebral vasodilatory reserve. Okay, what we call it as CVR, regulated by parasympathetic nervous system. Means, so if the value is less than 0.69, so the patient is less likely to maintain a constant homeostatic blood supply in response to some sort of the insult. A decreased breath holding index means failure of the collateral flow to maintain adequate cerebral perfusion in response to hypercapnic challenge. So it is used to identify patient at higher risk of stroke among the cohort of asymptomatic carotid stenosis or previously symptomatic carotid occlusion. So this is called breath holding index. So vasomotor reactivity, we can get idea by using something called breath holding index. So the sympathetic nervous system control of intracranial flow can also be tested. The patient is asked to hyperventilate and MCA flow is continuously monitored. So hyperventilation induces hypocapnia, means CO2 is going to be washed out and it is going to create respiratory alkalosis. That result in cerebral vasoconstriction, so which leads to reduction in flow velocity. So tell them to hyperventilate, CO2 will wash out, so which leads to cerebral vasoconstriction. So definitely which leads to reduction in flow velocities. That is how we can get some idea about the intactness of the sympathetic nervous system control on the intracranial flow. So vasomotor reactivity is mean flow velocity at hypercapnia minus mean flow velocity at hypocapnia, means after hyperventilation, divided by mean flow velocity at rest into 100. So a value of more than 65% indicate normal vasomotor reactivity, while the value of less than 33% reflect exhausted vasomotor reactivity. So vasomotor reactivity between 33 to 65% represent borderline impaired autonomic control. So these are some of the additional data which we can get as a clinical application by using TCD. So this is the figure, the assessment of cerebral vasomotor reactivity in a patient with a large MCA stenosis. Okay, so CT angio of the brain. This is the CT angio of the brain, shows a severe stenosis of the right middle cerebral artery. So it is severe stenosis here. So panel B shows the flow response in both MCS. A normal flow acceleration during 30 seconds of voluntarily breath holding is noted in the left MCA. Okay, so this is the normal appearance in left MCA after 30-second breath holding. However, the right MCA shows a paradoxical reduction in the flow velocities. So the flow velocities are reduced in the right, means paradoxical reduction in the right MCA, suggestive of an exhausted vasodilatory reserve with intracranial steal phenomenon, what we call it as a reversed Robin Hood syndrome. So basically, so which tells about absence of some mechanism to maintain the constant blood flow in the intracranial vessel. So by assessing something called vasomotor reactivity. So what is the role of TCD in patients with sickle cell disease? See, we have a good pediatric hematopoietic stem cell transplant unit and all. Sometimes they request, okay, sir, can you do TCD on our sickle cell patient and all. So I used to do the TCD in sickle cell patient. So children with sickle cell disease carry a significant stroke risk. So around 11 to 12% of homozygous sickle cell patients develop ischemic stroke before the age of 20. So primarily result from stenosis or occlusion of the distal intracranial internal carotid artery and or proximal to middle cerebral artery. So basically, it is going to be occlusion of the distal part of ICA, so proximal to that of the MCA territory. So TCD can identify children with highest risk of first ever stroke and those in need of blood transfusion. Okay, so remember, it tells two things. One, risk stratification, who can have the stroke, and need of the blood transfusion, we can get an idea by doing the TCD. In a trial, TCD detection of time averaged maximum mean flow velocity of 200 centimeter per second and two separate examination was used to determine the need for blood transfusion. Okay, that resulted in about 90% relative risk reduction of first ever stroke. So the mean flow velocity, okay, so you have taken the average value of two separate examination. If the velocity is around 200, that tells the need of blood transfusion also, which indirectly reduce the stroke burden also. Very, very important. Okay, so this is one evidence, and the TCD and prophylactic transfusion program in effective in preventing overt stroke in children with sickle cell disease. So they concluded, so it has been successful in reducing the rate of first overt stroke, but with increased use of transfusion. Okay, so basically in an attempt to reduce the risk of stroke with a particular value of the mean flow velocity, we landed up with giving more and more transfusion. Additional modification to screening might further reduce the risk of first stroke, and studies alternative treatment may be beneficial. So this is one more trial, that is STOP trial, stroke prevention trial in sickle cell anemia, extended follow-up and final results. Again, it also showed some benefit of using TCD, one, to stratify the stroke in sickle cell anemia patient. Secondly, it also tells about the need of blood transfusion. So this is one more trial, okay, which got published in 2005 in NEJM, that is the STOP2 trial. The optimization primary stroke prevention in sickle cell anemia. Okay, so again, discontinuation of transfusion for the prevention of stroke in children with sickle cell disease resulted in a high rate of reversion to abnormal blood flow velocities and Doppler studies and stroke. So basically, so prophylactic transfusion prevents strokes in children with sickle cell anemia who have abnormalities of transcranial Doppler examination. However, it is not known how long transfusion should be continued in this patient. So basically, they tried to avoid the transfusion. So to prevent the unnecessary transfusion and all. So on the other hand, it increases the stroke risk and all. So we need to go for the TCD, get an idea about the need for transfusion. So that indirectly helps in preventing the stroke in sickle cell patients and all. So then what is the role of TCD in something patients with a cerebral circulatory arrest, that is a brain death? So cerebral circulatory arrest is seen in TCD as varying from high resistant to diastolic flow reversal, that we call it as reverberating to absent flow. Basically, it may be total absent flow or maybe reversal of the diastolic flow. So diastolic flow should be in a positive way. So peak systole, sharp upstroke in a stepwise manner. So there should be positive diastolic flow. When it is totally absent, or when we have a reversal, that we call it as a reverberating diastolic flow, that gives an hint towards the brain death or cerebral circulatory arrest. That is one of the clinical utility of the TCD. So TCD often used as a supplementary test for confirmation of the brain death. So TCD as a supplementary test for confirmation of brain death. So TCD can be used to help in diagnosing cerebral circulatory arrest in adult and children who are elder more than 6 months. Okay. So once a reverberating signal is found, that is a reversal diastolic flow is found, it should be monitored for at least 30 minutes in both MCS and the basilar artery to avoid false positive finding. So this is like diastolic blunting. So it is almost absence of the diastolic flow, or it may be gives an idea with a reversal of the diastolic flow, what we call it as reverberating diastolic waveform. So scanning protocol and algorithm in cerebral circulatory arrest a suspected patient. Okay. First, document arterial blood pressure at the time of TCD examination. So assess the MCA starting at the depth of 50 millimeter and basilar artery at 80 millimeter depth. So positive MCA or basilar artery end diastolic flow is found. So then obviously no cerebral circulatory arrest, means we are getting a proper positive, means the diastole is not in the negative aspect. Okay, so it is still in the like positive aspect, not below the baseline. So then it tells there is no cerebral circulatory arrest. So absent end diastolic flow, that means uncertain cerebral circulatory arrest is there. So it is too early or too late to comment. So reversed minimal end diastolic flow, that means possible cerebral circulatory arrest is there. Continue monitoring, document diastolic blood pressure, which is around more than or equal to 50 minutes of mercury. So reverberating flow. So probable circulatory arrest is there. Confirm both MCA at 50 to 60 millimeter and basilar artery at 80 to 90 millimeter. So total absence of like diastolic waveform or reversal of the diastolic waveform gives some clue possibility of the cerebral circulatory arrest. Okay, so this is again the waveforms here. Normal MCA, peak sharp upstroke, that is a systolic upstroke, and diastole in the positive side. Okay, so increased ICP with a decreased perfusion pressure. So there is almost absence, near absence of the diastolic flow. Somewhere it is reversed also. Cerebral circulatory arrest, so obviously reverberating. So end diastolic velocity waveforms are below the like baseline, that we call it as a reverberating waveform. So this is the basilar artery, the left MCA, okay, right MCA. There is no appearance of diastolic waves here. So somewhere it is reversed also. Here there is no reversal, but almost flattening above the diastole in the left MCA. So this is one of the 6-year-old male who underwent abdominal surgery for perforated bowel and had a ventricular fibrillation, cardiac arrest. Okay, so on day 4 there is no pupillar reflex and gag reflex. Then the TCD picture shows so almost cerebro-circulatory arrest. Okay, there is no flow at all. So TCD monitoring for vasospasm in subarachnoid hemorrhage. So this is one of the important clinical application of TCD in a neuro-intensive care unit or in maybe multi-specialty intensive care unit. If you identify middle cerebral artery through the transtemporal window, so this gives the waveform like this. This is the systole, so this is the diastole, somewhere here comes the mean flow velocity. So TCD can be used in a SH patient to detect asymptomatic vasospasm onset, follow the spasm progression, that it is increasing, decreasing, facilitate the vasospasm therapy, particularly to give milrinone, verapamil, okay. So, or to give like arterial milrinone or maybe nimodipine IV infusion and all. So, identify patients with severe vasospasm. So, then we need to consider some sort of angio with angioplasty and all, monitor the effect of therapies and intervention, and also helps in getting an idea about the detection of spasm resolution, whether it is disappearing or not. So, in patients with subarachnoid hemorrhage and signs of vasospasm, a submandibular approach can be used, or maybe we can go for transtemporal route also. So, MCA and ICA, so ratio, that is MCA mean flow velocity divided by extracranial part of the internal carotid artery, we call it as hemispheric or Lindegard index, Lindegard ratio. Okay, here if you see mean peak velocity, means peak velocity is around 285. For MCA, somewhere around less than 80 is the normal. Obviously, 285 peak velocity is vasospasm. Mean velocity itself is coming somewhere around 205. Okay. So, diastolic velocity is around 197. Pulsatility index is 0.63. If it is more than 0.65, it is problem. Okay. So, in terms of getting an idea about the increase in flow resistance. So, this is the value of mean flow velocity, Lindegard ratio, and vasospasm or hyperemia. Okay. Suppose if the mean flow velocity of middle cerebral artery is less than 120 and Lindegard ratio is less than 3, it is hyperemia. So, if it is more than 120, Lindegard ratio is 3 to 4, mild vasospasm plus hyperemia is there. More than 120, Lindegard ratio is 4 to 5, moderate vasospasm with hyperemia. So, more than 120 with 5 to 6 of Lindegard ratio, that is moderate vasospasm. So, more than 180 with 3 to 4 Lindegard ratio, predominantly moderate hyperemia with mild vasospasm. So, like more than 180, 4 to 6 Lindegard ratio, moderate vasospasm with hyperemia. So, when it is a Lindegard ratio of more than 6 with a mean flow velocity of more than 180, patient is having a severe vasospasm of the middle cerebral artery. So that we need to understand. So TCD monitoring for intracranial pressure. So when we measure pulsatility index, it is the peak velocity, peak systolic velocity minus end diastolic velocity divided by mean flow velocity. That is the pulsatility index. So normally it should be between 0.6 to 1.1. If it is more than 1.1, somewhere between 1.1 to 1.6, there is a mild intracranial pressure. So 1.6 to 2, so moderate intracranial pressure. Severe ICP raised if the pulsatility index is going to be more than 20. So as I already told, so it is the difference between systolic velocity minus diastolic velocity divided by mean flow velocity, that is the pulsatility index. So this is the peak systole, this is the mean velocity, this is the diastolic flow velocity. Okay. So there is something called fast track ultrasound in acute cerebral ischemia. So high yield accuracy in diagnosing lesions amenable to interventional treatment, both in patients eligible as well as ineligible for thrombolysis. We can do the TCD. So that is lesions amenable to intervention is defined as an occlusion or near occlusion or more than or equal to 50% stenosis or thrombi in an artery or artery supplying the brain area affected by ischemia. So basically, to get an idea whether the lesion is amenable for intervention or not, so we can get by using TCD. Okay, so that is one of the add-on advantage. The diagnostic yield is particularly high when performed early after symptom onset. More than 70% of the patients who have significant and fixed neurological deficit show an arterial occlusion if examined within the first 6 hours of symptom. So up to 90% of patients who receive IV tenecteplase, tissue plasminogen activator, within first 3 hours of stroke onset demonstrate acute occlusion on TCD. So basically, if you're done within 6 hours, you can get an idea about the amenability for neurointervention. So particularly if the pre-treatment, so NHS score is more than 10, so then they are more good candidate for doing the acute thrombolysis. So experimental evidence suggests that ultrasound substantially increases the thrombolytic effect of tissue plasminogen activator. So particularly if used with a low megahertz or gigahertz frequency range. So other than getting an idea about the risk stratification and those who need intervention, it also helps in increasing the thrombolytic effect of tissue plasminogen activators. So ultrasound exposure causes various changes like reversible disaggregation of uncross-linked fibers. So microcavity formation in the shallow layer of thrombus, increase in enzymatic transport of like tissue plasminogen activator, improving its uptake and penetration of tissue plasminogen activator into the clot, residual flow enhancement with microstreaming and vessel dilatation. So these are some of the experimental evidence. So other than some diagnostic help, so TCD also having different mechanism so that it potentiate the thrombolytic effect of the tissue plasminogen activator. So what are the overall advantages of TCD? It is non-invasive, moment to moment change, we can get an idea, bedside assessment of cerebrovascular hemodynamics, continuous monitoring for emboli detection, absolutely safe. So contrast agents are not used. No IV contrast, okay, no radiation exposure and all. So, but we need to understand certain limitations of TCD. So it is operator dependent. So technique require detailed three-dimensional knowledge of the intracranial arterial anatomy. Secondly, TCD is hampered by the 10 to 15% rate of inadequate temporal window. Means getting a window is a problem, most commonly seen in blacks, Asians, and elderly female patients. However, the temporal resolution and convenience of TCD make it a vital asset to observing the evolution of blood flow changes in critically ill patients. So it is having limitation, it is having many of the clinical application, okay, but we need some amount of training when we perform the TCD at the bedside. So that's about TCD. So at least try to remember which are the windows, what are the clinical utility, okay, what is peak flow velocity, mean flow velocity, end diastolic velocity, how to get an idea about the vasospasm, Lindegard ratio, pulsatility index, resistance index, how to get an idea about cerebral circulatory arrest, vasomotor reactivity. So these some salient important points you need to remember on transcranial Doppler. Thank you.